I've been a doctor for 10 years, going 11 years now. I've been a surgeon for 4 years. So it's taken almost a third of my life.
I did my undergraduate, at the University of Nairobi, 5 years, and then did my internship. After internship, I did a medical officer period for 2 years, and then I decided to come back and do my master's in surgery, which is 5 years. So currently, I am doing my second year going to third as a consultant in general surgery.
I did my undergraduate studies in Egypt for 6.5 years. I graduated in 2010, and then I started working in Aga Khan Hospital, Nairobi, as an intern and then as an MO. And during my internship, towards the end of my internship is when I discovered my passion for surgery, basically. And then I applied for my master's here at the University of Nairobi in 2015. Currently, I've done 3 years, and I have 2 more years to go.
The training takes 6 years. That is after undergraduate training. So I did 6 years for neurosurgery training.
I'm a general surgeon.
I'm currently a surgical resident.
I'm a consultant general surgeon.
I am a neurosurgeon.
Most female surgeons in Kenya are venturing into general surgery, orthopedics. There's an increase in the rise of female surgeons in orthopedic surgery. I've seen a few in pediatric surgery and some subspecialties, and we're currently having one who's training for pediatric cardiothoracic surgery. So there's a great rise in the number of female surgeons who are subspecializing into practical specific subspecialties.
The history of women in surgery dates as far back as the history of surgery itself. In the Middle Ages, specific regulations were put in place to forbid women from practicing surgery unless, 1, they were widows who would assume their husband's practices upon their deaths, or 2, unless a competent jury would deem them fit. In England, King Henry VIII is said to have proclaimed that no carpenter, weaver, smith, or woman would practice surgery. Women had to impersonate men in order to practice surgery. But now, times have changed and we have women freely practicing the trade. In Kenya, the first female surgeon, Dr. Roslyn Omolo, was registered by the Kenya Medical Practitioners and Dentists Board, paving way for the many women, albeit still few, practicing surgery.
In our institution, half of our faculty is female. So out of every 1 man, there's a female consultant general surgeon.
Coming from small numbers of neurosurgeons in the country, as low as 15, and now we have 35 qualified neurosurgeons. That is very impressive. And this, I'm talking about 98% of those neurosurgeons who have doubled in the span of 15 years have actually trained here locally.
For you to be a surgeon, you had to almost take up that role and take up some masculine features, and you'd have to work an extra mile to prove yourself as good as a female surgeon. So most of the surgeons, I would say, would not forthrightly come out and say they are practicing surgery, and to some extent, the female herself would be the one to put you down if you were going to express an interest in surgery. But by and large, we're getting more female surgeons who are proud to be surgeons, proud to be mothers, proud to be in the field.
It is so difficult to say this is the right time to have a family, this is the right time to get married. I think the first thing that they should do is really be certain that that's the career that they want to pursue. And a lot of times I find that having a mentor, in terms of, it can be an academic mentor or it could be someone like a soft mentor who, you can go to their house, have coffee, someone you can be real with, not just discussing, oh, I saw this paper on a Journal of Bone and Joint Surgery and I think I can do a similar study. There's place for those academic mentors, and there are those who will tell you, yes, yesterday I came home late, I didn't see I wasn't able to see my kid before they went to bed. Someone who can just share with you the challenges. So having a mentor is like a really, really important step.
Every time KCSE results are announced, a few successful candidates would talk of their dreams to be doctors and surgeons in particular. Some of these female surgeons' dreams date back to such a time.
I realized I wanted to do surgery way when I had just finished secondary school, and they were receptive. I went to a hospital and I saw surgery and I loved it.
I'm not one of those who decided I want to be a neurosurgeon when I was a child. So I did my undergraduate, and while I was studying my undergraduate, I looked at the specialties that were available and how I felt I fitted into the specialties based on my personality, what I like, what I'm comfortable with, what I find straightforward for me. And by the time I was finishing undergraduate, I knew surgery was what I wanted to do.
For me, I think I'm a more of an action-oriented person. So when I was finally exposed to the actual surgery as a practice, assisting in theater, observing, I kind of made my decision from third year. I already knew that's what I was going to do.
It was getting the rapid results where the patient comes in, they're in pain, they're sick, then they need a surgery, you take them to theater, and then the next day they're doing well and they're so happy, and it's really fulfilling. So that might be the reason.
When they say looks can be deceiving, well, looks can be deceiving. Some members of the public have been noticing the petite, or if I may say, young-looking doctors that have more often than not been called erroneously students or nurses. These female surgeons have not been spared.
You're just doing your job, and yet someone comes in with the first look, they've already judged you. They've already found you to be, you can't be. There's no way you would be the surgeon. And that kind of hurts because you're a human. You worked really hard. I used to be told that, you look so small and young. You don't even look like a doctor. When they come and see someone who just looks like a student, they'll be like, okay, we're waiting for the real doctor. This must be the nurse or the student who's preparing me for. Then you tell them, actually, I'm the one who's going to be doing the surgery.
You find so many times you get comments like, oh, don't you think you're too small? How will you reach the operating table? Or what does your husband think? So who will raise your kids? I was even told straight into my face that even your fellow women would not trust you as their surgeon.
When a man enters an area of work and a lady enters, the people working there or the patients might perceive the man to be the doctor first before they consider the lady to be the doctor.
I've had instances where my residents, we've operated with them, but the residents, the ones who are training, the patient will ask the questions to the resident just by virtue of the fact that he's a male, maybe he's got like facial hair, so he looks a bit older.
I cannot tell you for what number of time that you will be working, and I have told myself it's okay to be called sister. If you're in a Kenyan society and you're a woman doctor, not a surgeon only, you're called sister, just because they do not expect that you can actually be a doctor, or some patients might find it hard to entrust their lives on you as a female doctor. But worst case scenario is you coming into an operating room and a staff member questioning your ability to do a procedure just by the mere fact that you're a female doctor.
Gradually, I came to see, okay, my parents also do the same thing, like inadvertently. They're like, I met someone, but they're really young. Maybe they don't know what they're doing or they look like. So I tried to kind of take it from the patient's point of view. Okay, if I was a patient, what would I like my doctor to exude or to exhibit? So I try to incorporate that when I'm talking to the patient, no matter how. So I do my part, and I think I go like maybe an extra mile just to kind of put them at ease that when you're coming into this surgeon-patient relationship, this is what I'm offering to you, okay? And then you can make your decision because everyone has a choice. You can say, okay, maybe I'm not comfortable with Dr. Mbabu. I'll go see her senior, or maybe I think she's the right person. But I'm in a position where I'm like, I'm confident in who I am. I don't think there's anything left to prove.
Generally, there is that perception that the male gender is people are more accustomed to. I would say it's a cultural thing that develops with time.
In the field of surgery is still sort of considered a boys' club. So when a woman is in there and if she makes a mistake, most people would say it's because she's a woman. So you find us women trying our best to learn more and to perfect ourselves and take our time to do the job right. Being a woman sometimes,
I think it invites this response by our male colleagues that they feel like we have to be explained to everything. Sometimes they have this perception that maybe a woman that can't really stand the whole goriness and all the intricacies that come with surgery. A lot of them feel sometimes you're not, as aggressive as them. So in as much as you know the procedure, you might not be as sometimes that might be a challenge because you don't really advance as quickly as your male colleagues.
What I would say about neurosurgery is, one, it is a very delicate specialty of surgery in terms of how it differs with other fields of surgery. It's extremely delicate, requires a lot of details, and requires also time. The time input is also quite significant compared to the other surgeries. Most surgeries you'll find on average people will be working maybe longer surgery in other fields, maybe 3 hours, 4 hours. In neurosurgery you can have a surgery that will last even up to 10 hours. Sometimes we've even worked more than 16 hours on a surgery, with the shortest case probably taking minimum 3 hours.
There are no set hours. There might be times when you're called back to come and do emergencies. There are times when you'll be forced to decide what comes first. Is it your career or is it your family? And at what point you want to rise in terms of career or grow your family. So having thought about that, some of the unique challenges would be leaving the house early and sometimes being in theater 2 odd hours.
If you're planning to start a family, for my male surgical colleagues, they just make a decision, and there's, their partners, they take the load, they bear the child, they go through their pregnancy, they deliver, and the male colleague is still continuing with his life. I, as a female surgeon, if we decide to get pregnant, I have a child now, I'm the one whose career stops. My work might be affected. I might have nausea, early morning sickness. I still have to report to work. I have to stand for long. I'm pregnant. I have to avoid x-rays. Things that you never really think of, and now that's a unique situation. But I think with more and more ladies coming on, these are challenges that now we're getting to talk about, because in the beginning there was no conversation about them.
Female surgeons, like any other female worker, goes through the challenges that come with pregnancy, breastfeeding and motherhood. How did or do these ladies navigate through this?
The patient bed changes. It can go up and down. And as a surgeon, you do not operate in one, there's no one particular position. You can, move yourself depending on the trimester that you are. So first and second trimester, pretty much okay. Your third trimester, if you're a consultant, maybe consider teaching more, allowing a colleague or an assistant to assist you.
I was lucky that my pregnancy was not really complicated. I didn't have much of nausea or sickness. I got really tired towards the end, and I had quite a bit of weight gain. So the whole standing and things, it just used to leave me breathless. But what I was able to do is, at least I was able to negotiate, or rather have the option of choosing what surgeries I can do or what I can do. In the last trimester, towards the last 3 weeks, when walking was a problem, even climbing stairs was a problem, I'd only do minor cases that allow me to sit down. In the event that I have to stand, even the belly comes in the way of actually getting to the patient. I remember there's one laparotomy that I had to do as an emergency, and I mean, I was just struggling. Like, it was hot. I was feeling like I was going to faint. And luckily, I had told my boss, one of my bosses, that I'm going in, so, because it was like a critical patient. So he was able to come and join me, just, lucky enough in time.
Thank God my pregnancies have been calm, let's say. So I didn't have that first trimester, that hyperemesis and all, so I was just okay. And I was like, when I was pregnant with my second child, I was working in an ICU. I was okay until towards the end. I was actually still working on the day when I went into labor. So I finished my shift, then went to labor ward to deliver my baby. So thank God my pregnancies have not been very taxing. It's just towards the end where you feel more tired. You're not so active as you usually are. Currently I have a 7.5-year-old and a 5-year-old, both going to school. It's quite tough. Like, I've had instances where during internship my baby was an infant still breastfeeding, and I'm on call. I cannot get out of the hospital, so my husband would have to bring my baby to the hospital and I breastfeed in the parking. The important thing is having a support system, a very good support system, a husband who understands and supports you. Thank God mine supports me both financially, emotionally, psychologically, because he's also been a resident before, so he knows how it is. I have someone who does my groceries for me. I just call and then send someone to pick. I've rarely go to the market. I rarely go to the butchery. As in, yes, the important thing is to have food in the house, but it doesn't mean I have to go get it myself. So such things you delegate.
Some days you may have to give more time to work, some days more time to other things, just depending on how the day is. And with time you learn how to balance, and it is no longer an issue.
It was tough. It was tough, but I was very lucky that I had such a good support network. My workplace, first of all, is very empowering to women. It actually has a lactation room. Not many institutions have that. There's also a culture in the staff. My fellow colleagues, the doctors, the administration, even the nurses will come and ask you, have you taken your break? Have you gone to Express? Do you have enough water or, drinks to keep you on? There was the facilities themselves, there's a fridge. I can just take a break if I want to. I was also lucky because I live quite close to where I work. So in the very acute instance where I need to have breast milk delivered to my child, at least that was an option.
There are situations where you might be stuck in the operating room and someone is trying to get to you, and you have a sick child. So different hospitals would have different systems in how you're able to answer the phone while you're operating, but then knowing who's your fallback mechanism. So in my situation, my spouse, and the fact that I am close to where I work. So that can also factor in. You have to establish a good supportive system, and that can be different female surgeons coming together, or a community at home, or your spouse, a supportive spouse and family.
When you get back to work as a lady, whether it's the 4-month mark or the 3-month mark, your milk supply, inevitably, it will just shut off. So, and the more stressed you are at work, you're not seeing the baby often, the milk supply goes down. A lot of my colleagues have also had to just introduce their babies to formula a lot sooner than they would have wished. And not because they don't want to, everyone wants to breastfeed even for 2 years, but circumstances just define that. So I've just been very lucky. I've also had the support of my nanny. She's been with me since my son was born. It kind of puts your mind at ease, and it lets you do what you're meant to do at work. Don't be afraid to ask for help. Like, you feel like maybe, I'm leaving my kids at my mom's too often, or I'm calling up my husband to leave his job too often. No, just, you kind of have this agreement that you have to achieve certain things with your family. Maybe it's, maybe every Sunday you spend it this and this way. So if you have that in mind, plus a support network, and you have to sometimes take it easy on yourself. Like, you're not going to get everything right every day. There are some things There are sometimes you'll just come and find the house is in shambles, no one has eaten, you've not shopped, things are just crazy, people are calling you at work, and you're like, it's one of those days. And then the days where you get home, you can have the luxury to spend time with your family, you can cook, you can enjoy a good time with them. That's like what we strive to get to, but it's not always possible.
Well, you're having more female surgeons, you're having more female students, and we have family, they're pregnant, so why not create policies? It's a bit sad when you've just delivered and the expectation is you have to go to work 2 weeks after you've delivered a baby. So those are some of the challenges, and having more women in leadership, surgical leadership, would improve our call. But I take it back again because sometimes the woman is her worst enemy. Yeah. So there are some female surgeons who would want to feel, I want to be like a man or to show myself to be macho, so yes, I can come back to work after 3 weeks. In reality, the baby or you end up suffering. So we have to be open about the challenges.
For me, I've been lucky because the teams I've been working with have not shown any issues with having ladies in the field. The neurosurgeons I've worked with, or the other surgeons I've worked with, we've been able to work together well without the issue of gender arising. In fact, I would say most of the time after I've worked, I would go we would attend like a conference, and I actually don't realize like sometimes I'm the only lady, or maybe we are two, until I see the pictures and I'm like, oh, okay, I actually didn't realize. That's how well we were able to blend in with the surgeons of the male gender.
Several studies have shown that female surgeons have better clinical outcomes than their male counterparts. Why is this?
As you operate, as you get to learn how to practice surgery, there's patient selections. There'll be situations where you have the chance to electively choose the patient that you want to operate on. And given the fact that you're keen in what you do, then you would set out to choose a right candidate for your procedure. However, in emergency situations, you don't get that opportunity. So you have to learn that in as much as you can be careful, there are some outcomes that you can't determine, and the outcomes are not gender-based.
Through what lens does the public see the doctor?
The public that I've dealt with, sometimes they place doctors to a very high standard of kind of perception, if I can call it that. I think, they think we don't even get sick ourselves. There's a time even I was telling one of my patients that, I'm not really feeling well, so they're like, oh, daktari hata wewe unagonjeka? Hey, sasa ukigonjeka nani atatusaidia? And I'm like, well, unfortunately, even I have this problem.
Just because you're a doctor, they assume, but you're a doctor, how come you're sick? So, yeah, but other people do, others don't. And you just have to keep explaining to them and reminding them that at the end of the day, I'm still a human, I'm still a woman like any other woman.
Worst case scenario, if you got ill or someone had an accident or you lost a spouse, they might not feel your pain, right? They can try to empathize, and I would not expect them to feel my pain in a way because they are also sick. So the best I could do is openly excuse myself and offer them the best that I can, which would be my colleague or my assistant, and then attend to my family. Because if I don't, then I also suffer as a surgeon, my family suffers, and eventually the patient will suffer.
In a certain way, you can understand why they're not able to conceptualize that you're also a human, because they also bring their problems to you, and they're expecting you to take the load and not, for them it's easy to blank you out, just make you a part of the process and not really a human being, because it's necessary for them to just unburden themselves, seek help, and just proceed with treatment.
Are these lady surgeons happy with where they are so far?
My best moments actually are when I'm in theater, when I am operating, and it's the surgery that I have reviewed a patient, I've seen the patient, I made a decision that this patient requires a surgery, and I go in and I operate, and I come out, and post-operatively I see the patient improve. That is usually my best moment.
Every day that I interact with a patient, and not just even the cutting, but just, I meet a patient in the breast clinic, and, we make a diagnosis of something. Even just interacting with them, just getting how they've gotten to be there, what their fears are about the surgery, me explaining to them that, believe it or not, people get cut and they come out of theater every day. Being able to do that operation successfully, the patient goes home cured without a complication or without any major incidents. That is like the bulk of what brings me, joy, just dealing with someone.
I'm at a point where I am teaching, I am a consultant, and I have my family, and I can balance the two, and I can start thinking of how to change and make policies. This culminates everything. And I would say just having a supportive team work with you.
But it is not always rosy.
You being sick as a female surgeon is deemed that you're a weaker sex, or you getting tired would be deemed as that it would match up to what you provide as a surgeon, or you asking for a seat to sit in the operating room just because you're a woman, you're a woman surgeon, and you asked for a seat, oh well, she's not going to perform just as much.
My lowest moments would be the moments when you've lost a patient, despite you knowing that you've tried your best and there's nothing else that could have been done, but you still lose the patient, and having to now tell the relatives that you have lost your loved one. It's really, really tough, and you never get used to it. It's not easy.
The landscape is changing positively for women in surgery.
You as the woman has to decide, well, at this point in my life, if I am studying, can I do both of them together? I know I have. Try to balance it, and what is my support system? So is it good enough for them to be able to allow me to be pregnant while studying, or pregnant as a consultant? And what does my partner or my other family member, what do they want? Are they willing to help? If I think I should wait for 2 years to have a family, then it's okay. It's okay to read, finish reading, be a consultant, and have your family.
I did not perceive a huge difference in terms of how to relate with my colleagues, how to work with them, because for me, I felt as long as someone has what it takes, the gender issue doesn't arise.
People are individual. Whatever works for you. Like, I got married after my residency, but that's because that's how it just worked out. If I could, maybe if I had the opportunity or things were different, I would get married during residency, before, who knows? But like, this is now what God's plan was. So you kind of just have to roll with the punches. I don't know if that's too cliche, but that's usually the best approach, I feel.
Surgery is very, very fulfilling, but it's important for you to know why you're getting into surgery. It's not Grey's Anatomy, because you find with all these TV shows right now, people have a misconception of what a surgeon is or what surgical residency is, and that's not it.
With more women venturing into the trade, the trailblazers caution that it is not showbiz, neither is it for the faint-hearted. Dr. Mercy Korir for Health Digest, KTN News.